outline topics surrounding Parkinson's disease. Before I turn to the next slide, can we just throw out like a couple ideas, like quick review about Parkinson's disease, like what do you guys know?
As usually symptoms of Parkinson's, a lot of motor disorders, like rigidity, slowness, and movement, walking. It's a neurodegenerative disorder.
Yes. There's no cure, no drugs,
Yeah. So it is, like Karina said, a chronic neurological disorder. It affects 1 out of 100 people, usually ranging, when I was looking into my studies, it was like, it ranges around 40 to 60, but it can go above 60. But it's usually around 40 to 60 where it starts. So it can be misdiagnosed because there's no way for clinicians to actually like pinpoint it. The disorder is of the central nervous system, so it's cause of loss of cells in parts of the brain in the substantia nigra, which is directed towards dopamine. I'm going to talk about dopamine a lot. So I put the actual definition of it is a chemical messenger responsible for transmitting signals within the brain that allow for coordination and movement. So without this, as you can probably guess, you're going to lose your movement. So the patients are going to have less control of their body movement. The cause of Parkinson's disease is unknown. However, research can point to genetic or environmental factors. Some treatments are dopamine agents, so adding dopamine to what is being lost by the loss of cells. And then the COMT inhibitors. And does anyone know what these are? I thought it would be familiar. It's a drug that inhibits, I have to look at it, catechol O-methyl transfer. So this enzyme is involved in degrading neurotransmitters. So I thought I'd just add that as like a little fun fact, because I know you don't really know. Okay, so the two topics I'm going to talk about today are Parkinson's disease and sleep, and then controversies in Parkinson's disease. So topic 1 is Parkinson's disease and sleep. Just a little side note, over break, I got a puppy and a pig, so you might see puppies and pigs around this presentation. So for this one, I wanted to ask how much sleep you guys get. So like how many hours per night do you think you would get sleep on average?
7.
really fun. 5. 6.
Yeah.
Waking up every day.
Yeah. I want to say that I get 8, but I probably am around 5 or 6. Like so Parkinson's disease and sleep. The common sleep problems that are said to be a possible early sign of Parkinson's disease is insomnia, excessive daytime sleepiness, nightmares, sleep attacks, REM sleep behavior disorder. The REM sleep behavior disorder, this is when you act out your dreams, it's said to be. Sleep apnea and nocturia. Nocturia is frequent nighttime urination. So there was a study done by UCLA researchers, and they found the association between Parkinson's disease and narcolepsy. The study revealed that patients with Parkinson's disease and those with narcolepsy both display a loss of hypocretin. And these are cells in the brain, and the loss of these cells are correlated with the severity of PD. Parkinson's disease is one of those diseases that gets worse over time, and it really affects the quality of life of the patients. But the study did not prove that Parkinson's disease patients are at risk of narcolepsy. It's just kind of like an early warning sign, possibly. The connection between REM sleep behavior disorder, and that's the acting out of dreams, and the development of Parkinson's disease. The study was done, researchers found that up to 75% of the patients with REM sleep behavior disorder went on to develop a Parkinson's disorder. So, and PD patients are reported to experience drowsiness throughout the day, just kind of as, I would kind of say a side effect, possibly, because it never really talked, in my research, it never really talked about it getting too severe, so it was kind of just a mild drowsiness. 76% of the PD patients experience this. That's what one of the studies that I looked at showed. Sleep-related symptoms have a major impact on quality of life, like I said, for Parkinson's patients, and treatments for these problems should be integrated through their therapeutic processes. So, as well as Parkinson's disease, as they're trying to be treated for Parkinson's disease, they're usually treated for sleep disorders as well. So another study focused on timing and duration of sleep in patients. A 12-year study by research at the National Institute of Environmental Health Sciences of U.S. National Institutes of Health. It's a pretty long name. 1 million nurses they studied. They all worked the night shift, and they were at a lower risk of Parkinson's disease than those people who got at least 9 hours of sleep or more at night. So they found that people who actually got more sleep were more at risk for Parkinson's disease than the nurses who worked the night shift, who probably got less sleep than that. Sleep symptoms in patients with PD treated with medication used for narcolepsy, and this the narcolepsy treatment seemed to help with a lot of their sleep issues that they had. Sleeping issues can be seen in the early stages of PD and can worsen as the disease becomes prominent. So it kind of goes hand in hand with the disease. As the disease worsens, so does their sleeping issues, which puts a large strain on their life, because I know as college students we don't get the sleep we should, and I know sometimes it can affect us negatively. PD and sleeping disorders progress in the same manner, just like I said. So what conclusions can we make based off this? Like, why do you think as the Parkinson's disease progresses, the sleeping issues also progress? When I first thought of this, I kind of thought back to maybe as the Parkinson's is getting worse, it can put more wear on the body, causing them to have more sleep issues. Because I know if you're not in the right state of mind after not sleeping for a while, it causes more effects on the brain. Treating these sleep disorders is super important for the patient because it'll affect their quality of life. Like I said, we don't get enough sleep, we're not working at our best, especially when they're trying to overcome their symptoms that they already have from Parkinson's disease, and now they have to overcome sleeping issues. So does anyone else know concerning the brain what would be damaged during sleep disturbances? So if you didn't have Parkinson's disease and you just had like insomnia, narcolepsy, see what other parts could affect.
Ponds, is that right?
Yeah. Yeah, those were my two that I thought of. So the second one is controversies of Parkinson's disease. The kind of subtopics that I'm gonna catch on here is dopamine again and dopamine agonist. The treatment, which also involves dopamine agonist, and dyskinesias. So to talk about dopamine again, I put the definition in again, which is a group of neurotransmitters in the central nervous system acting in the brain to help regulate movement and emotion. Too much of this can have an effect on the brain, on movement, and too little of it can have effect. So you have too little of it, you're going to have problems, which Parkinson's disease is the loss of this, and too much of it could cause dyskinesias, which we will talk about in a little bit. So there are concerns in that dopamine would be neurotoxic. So just by looking at their word, does anyone know what it means?
Destructive of the brain.
Yeah. So harmful. It could be harmful to the brain or the neurotransmitters. ELL-DOPA, I've been calling it L-DOPA. I'm not really sure if that's the real term, but that's the study they did that they proved that dopamine can be neuroproductive as well. So in contrast to neurotoxic, neuroproductive would be productive and helpful to the neurotransmitters or the brain. So that right there can show you that too much or too little can affect it in so many ways. That's why doctors are very careful when they place patients on dopamine and dopamine agonists. So patients with early stages of PD are placed on, in this study, they were placed on either the placebo or various strengths of the dopamine. They were placed on 150 to 600 milligrams daily, so just scattered throughout. They were given the different doses. So the group of 600 milligrams daily did not deteriorate to baseline, and the group of placebo remained significantly worse, just showing the effect of dopamine on the brain and the neurotransmitters. And with Parkinson's disease, it's mostly on how it affects their movement. So dyskinesias, these are abnormality or impairment of a voluntary movement. They're complex based on dopamine in the basal ganglia. Like I said, too much, too little can affect this. And it will affect how severe it is. In the Mayo Clinic study, dyskinesias are uncommon in the elderly. They found that once you're over 60, if you start developing Parkinson's disease, you'll have a less risk of getting a dyskinesia if you were in the 40 to 55 range. Like I said, they can range in severity, and it's basically just, they're based on the patient's movement. It can be so severe that it might have to be intervened surgery. So a dopamine agonist is a compound that activates dopamine receptors in the absence of receptors psychological ligand in the neurotransmitter dopamine. Dopamine agonist activates signaling pathways through the dopamine receptors. To me, dopamine agonist is kind of a stepping stone to go full-on dopamine. It is less effective, side effects are more severe, and it's expensive. That's why there's controversy with using it as a stepping stone, and patients should be able to, patients would be more prone to dyskinesias if they just started them on dopamine right away. So they try to start them on dopamine agonists, kind of like a stepping stone, because they don't want them to get too dependent on the dopamine alone, and then just keep increasing it and putting them at high risk for dyskinesias, which can lead to surgery. Like I said, their first choice is dopamine agonist, and it's just kind of reiterating what I said. Again, too much, too little dopamine can cause dyskinesias, which is not good. So they want to start them on the lowest form possible. And like I said again, they might have a feeling that it's wearing off more and more causes dyskinesias. And that's the end, and that's my actual pagan puppy. And are there any questions at all?
So,
Why did you choose to focus on sleep and the controversy treatments?
I thought when I was looking through, I just typed up topics, and both of them came up. When I started reading, I was like, wow, these are both very important, and I don't want to leave anything out of them, because I think the controversies of the dopamine agonist versus just right onto dopamine are important to know, and it kind of gives us insight into the patient's life along with the sleeping disorders, because I know a lot of us can relate with our sleeping issues too.
so I'm curious, when you were talking about dopamine controversies, is that that phrase, is it something that you came up with, or did you find in the resources you came up with that other people think this is controversy?
Yeah, it was in the research.
Okay, which sources specifically were talking about that?
I believe it's in the last one. I mainly used, it was a journal from a doctor talking about his views and then other views of his colleagues on what they think. Ultimately, in my opinion, I think it should be up to the patient. If they start on a dopamine agonist, if they're like, this isn't working, I still can't move right, I want better quality of life, they should be allowed to ask for a higher dose of dopamine. But I know how it can be an issue because clinicians don't want to put them on too much or keep upping their dose and put them at risk for more complications.
Do you think that patients know enough about the medication to recommend their own dosages?
I don't think they know about their medications. I think the doctors are capable of telling them that if too much, they could cause more problems. But I think they know their own body more. So if they're not feeling effects on it, then I think they have the right to ask for more, as long as it's in the right sense and they're not just asking for more so they can just completely feel better. But I think they, what's going on with your own body, and the doctor doesn't really exactly know how you're exactly feeling.
Okay. All right, any others? All right, thank you, Megan.